Good morning, everyone. My name's Ed Millenstead in the System Partnerships team here at the Innovation Agency. Very warm welcome and thank you for taking the time out of your busy schedules to attend our webinar on developing effective remote consultations in outpatients. So the Innovation Agency are the academic health science network for the Northwest Coast, and we work together with NHS partners and businesses across our two integrated care systems, which are Cheshire and Merseyside and Lancashire and South Cumbria. We're a fully funded NHS organisation with the aim of increasing the spread and adoption of innovation into health and care. So we're here this morning to talk about how we can develop effective remote consultation services for both patients and clinicians, and consequently see an increase to the usage rates and availability of remote consultation appointments. And positively, since the start of the pandemic, we have seen a rapid uptake of remote consultations in outpatient services. There's new ways of working have been adopted at pace. Our clinical and operational teams have managed a tremendous amount of change and upheaval to their traditional service models. And there's many benefits also to patients from remote consultations, clearly. But we're all aware that usage rates are now either flatlining or dropping off due to a number of reasons. And we want to make sure that remote consultation is sustained and not solely seen as a response to the pandemic. So back in the summer of last year, an appreciative inquiry was undertaken by the Innovation Agency, which looked at the enablers and barriers, what is working well with remote consultations, and we'll present the highlights from that report shortly and then move on to our interactive panel conversation. And I'm delighted that we're joined today for our panel by some trust representatives from St Helens and Knowsley Hospital, Southport and Ormskirk, Lancashire and South Cumbria Foundation Trust, Healthwatch together, and the NHSE Northwest Regional team for our panel conversation. Conversation with the panel very much is an organic conversation, authentic, from people with direct experience of remote consultations. We will have a chat box facility available during this webinar. It'd be great to hear your comments and thoughts and views. I'll be facilitating the chat box whilst our speakers are having the conversation, but the panel won't be taking questions directly. Rather, we'll do our best to manage those questions through the chat. So I'd like now to introduce Peter Jenkinson to you, who is the Chief of Digital Operations at NHS EI Northwest, to help set the current context for remote consultations. So over to you, Peter.
Thanks, Ed. Morning, everyone. Can I have the first slide up? Thank you. Just to give a bit of background around remote consultation and why it's important. So there's a strategic direction nationally to increase the use of video appointments and remote consultation in general, both in outpatients, and you also get a very similar approach in general practice. It's seen as an enabler to supporting the restoration of services and reducing backlogs. This was particularly seen as a real driver during the early stages of the pandemic, where it was difficult to get people into hospital, so we needed another way of getting as many patients as possible into the system to get some kind of appointment as safely as we could at the time. And as Ed alluded to, we now need to look at, well, how do we then take this forward in a more sustainable way? It was backed by planning guidance, which gave some very clear targets around the uptake virtual consultations, and it was seen as a real way of supporting clinicians being more productive with the time. So some of that you might see if you've got clinicians who are working across sites, and the use of remote consultation being able to support them not having to travel between sites and having to go into multiple different hospitals basically to bring people in to see them. It gives them an option of just being able to see them over either a video link or over the telephone. And there was a clear alignment with some of the wider digital pathways taking place, particularly around some of the key areas around cardiology. There was some orthopedics and MSK pathways that were coming out that were, there was a real digital input into those during the mid stages of the pandemic. Next slide, please, Ed, or the last one. What you'll see, there's 2 or 3 data slides in there that will come out as part of the pack, just to illustrate some of the reasons why we started to look at an appreciative inquiry. During the early stages and as part of the outpatient transformation programme run by the NHSE North West, we had an ongoing review of virtual outpatient activity. It captured appointment details for both face-to-face activity, but also the raw numbers and percentage that were delivered by both telephone and video. What we saw was some quite distinct variation in uptake, both across specialties. So you get a gap between something like urology, which, if you look in the slide out, was running at 50%, where you've then got something like a 14% and 15% drop when you look at something like MSK. So we couldn't really understand why that was, particularly then when you started to look at that across trusts. So Sharon, who'll be introduced later, did an awful lot of analysis around how that was panning out across the different trusts in the region. And there was no real pattern that seemed to be emerging in terms of why urology might be really high in this particular trust, for example, and it wasn't quite as high at this particular trust over here. We did have some generic lessons learned that came from a really good national survey that was undertaken, but it was very, the outputs of that were quite high level. It outlined a lot of good practice. It outlined a good number of the blockers to uptake, but what it didn't necessarily help us do was understand the differences in the Northwest as when you started to get down to the specialty and the trust levels. So, well, why is Trust X delivering this level of activity for this particular specialty, and Trust Y is somewhere in a different place? And it didn't help understand that. So as part of the work with the Innovation Agency, we effectively co-produced the appreciative inquiry that we're going to talk to. And what we hope to get from it was to begin to understand some of the underlying reasons for that variation, to produce some decent recommendations for taking forward virtual appointments, but to do it in a sustainable way. We've gone through a big push to get this technology in as part of COVID. It really was quite useful to do it, but it's dragged forward some of the original plans by a good 2 to 3 years in terms of the uptake of technology, and that will always have benefits and disbenefits from doing that. But what we wanted to see was how can we now take this forward sustainably without losing a lot of the momentum that was gained during that first or second wave of the pandemic. So with that, I'll hand you back over to Ed and the rest of the team to take us through the appreciative inquiry. Thank you.
Thanks very much, Peter, for setting the context there and the rationale, the reasons, the drivers for why we undertook the appreciative inquiry. And we'll move on now to present some of the key highlights, the key messages and findings from that report, and also be joined by my colleague Charlotte Hall, who's the Programme Manager, to support with presenting this summary messages. So as Peter's just outlined, so these are the overarching aims of the inquiry. It really was about surfacing those key characteristics of successful adoption. So what are those key principles or success factors that really underpin a remote consultation service, and so could be spread and applied to other organisations to help drive an increase uptake and reduce that variation in service provision that Peter was mentioning, and also so that we could understand what the actual barriers are to adoption, because if we know what the barriers are to remote consultation, then we can actually do something about it. And the inquiry provides, and the report, a blend of those operational and strategic insights, because it's very much a blend of the two to enable successful adoption, and to learn from what is working well from trust teams across Cheshire, Merseyside, Lancashire and South Cumbria. So how do we actually go about undertaking the inquiry? Well, just very quickly, we had about 40 facilitated conversations across 15 different provider trusts in the Northwest Coast, but also in Greater Manchester as well, which was great. And we really did speak to, as you can see there, a wide range of clinical professions, a variety of specialties. So that meant that we gained a whole host of clinical experiences, different clinical viewpoints, different operational experiences as well, around from operational outpatient managers, booking teams. So that helped create a really comprehensive and well-balanced report, which wasn't one-sided to one clinical group over another. So moving on to some of the key messages and the main points then that we found out through undertaking those 40-odd facilitated conversations, which was no mean feat to kind of distill it down into some headline messages, but we had to go, and this is what we found out. So just very quickly, really was a resonating view from the clinical teams that remote consultation, it is excellent. That was a resounding message when it's provided at the right time and for the right people. So there are many benefits clinicians thought of remote consultation to their work. It benefits their service to patients, but it must be at that right point in the care pathway and for the right patient groups. And that's why we've used the strapline, which is on the very front page of the report, and the link, you'll see the link to the report within the chat. It's also available on our website, which is a direct quote from the inquiry that reads, "For the right person, for the right type of healthcare at the right time, remote consultations can be hugely beneficial." But we're mindful that what works for one specialty and one patient group doesn't necessarily work for another. There is a common desire as well to use remote consultations where it's clinically suitable and appropriate for the patient cohort. We heard unanimously that it does have a place to varying degrees in outpatients. There's a common desire to adopt and use it, which is fantastic. But for it to be effective for everyone, including clinicians, the patient groups must be profiled as part of the design planning to identify those cohorts where it will work. And as we're all aware, a significant volume of remote consultations are clearly delivered via the phone, and that is much easier to do. But there is a strong opinion and clinical view that video allows for more effective care, a greater quality of care to the patient. But we're all aware it's much more operationally challenging to implement, and it really does depend upon the clinician's desire to use the technology and whether or not they have the digital skills and capability to use it. Turning on the software is very much only the start. We're all aware about the huge amount of change that any digital service brings in, both for patients, clinicians, operational services that underpin those. And remote consultations clearly is large-scale change. It's a completely different way of working. So developing those cultures, those behaviours, and to support teams through that, investing in change management really is critical to enable it to work and to work through those, but that resource is often lacking. As we're aware, there's many significant process and operational challenges to be worked through, and that underpin the implementation of remote consultations. And dedicated implementation support is therefore essential to that, due to those array of process changes between booking teams, between medical and surgical secretaries, between receptionists, between the nurses or the consultants triaging the referrals. And so there's multiple support functions who remote consultation touches. And so due to that complexity, that can deter overworked and time-poor clinicians from developing it. Remote consultations generally are more appropriate for follow-up appointments as well. I think we're all very much clear with that, but as new appointments seem to work much better face-to-face, as the clinicians understandably really want to understand the patient's condition, examine the illness in person, and really get to know their patients first. There's pockets of best practice that exist in services, but these are not widespread. Many organisations we spoke with, there always was some stellar and standout remote consultation examples, be that as a whole specialty using remote consultations or individual certain consultants or specialist nurses using it. But for example, if one consultant or specialist nurse in gastroenterology has remote consultations and it's working well, it doesn't mean that the entire gastroenterology service will provide a remote consultation service to patients. It's not necessarily widespread. Many clinicians want to offer video appointments, but are hampered by inadequate technology, a lack of interoperability. So there are some quick and easy wins that can be done here to improve video usage rates, which simply focus around supplying sufficient kits and hardware, and that's of a sufficient quality standard, because it still isn't accessible enough for clinicians to use. Executive and clinical leadership combined with a strategic plan with appropriate resources is essential to enabling the rollout. So that coordinated corporate support is not always in place to oversee and drive forwards a structured rollout. And that has resulted in a range of trust services with different delivery models and often with considerable variation within individual services. There is scope to kind of standardize that and ensure we have consistent leadership within trusts and at a system level. There's much potential still to be realized relating to those workforce and productivity gains from remote consultations, but addressing those operational, technical, cultural complexities is critical to actually harnessing and leveraging those productivity and workforce gains. So we're still very much feels like we're in the early days with the technology, which is completely understandable due to the pressures upon the NHS as a whole due to the pandemic. But there is greater potential which could be realised from remote consultations. And final point, but by no means least, is around patient choice, and that really should be central to the decision about the appointment method for patients. That's kind of a quote from the inquiry, which was to allow people to choose the mode of remote consultation that they want, and not to force video consultations upon them, because it's not for everyone. It doesn't necessarily work for everyone either. So choice is essential in providing the option to use it, but also we must ensure that there's equality of access to care. You know, we're all aware that we don't want to exacerbate health inequalities any further, and we must be mindful of that, as not everyone's digital accessibility or digital literacy is the same, so that we need to invest within that for our communities and local populations. I'll hand over to you, Charlotte, now.
Thanks, Ed, and hi everybody. I'm going to talk to you a little bit now about some of the benefits, the barriers and the enablers that were raised during the conversations we had with the teams last summer. As Ed alluded, the report is packed with lots of rich content that we heard from people. So we're not going to be able to do it justice today, but I am going to be able to just give you one or two examples of each. So starting with the benefits, you know, we heard many benefits throughout the report. The patients particularly noted many benefits, saying that the use of remote consultation saved them time, saved them money, saved them kind of travel stresses, and was generally just much more flexible for them around their existing commitments. We also heard some benefits from our staff and in the workforce. We heard that it generally contributes towards a better work-life balance because it's enabling more home working or more general flexibility of base, you know, not necessarily needing to travel between multiple clinic sites. And then from an operational and clinical point of view, we were hearing that backlogs were being triaged more efficiently, that there were fewer DNAs, and then obviously the big positive during the pandemic around the reduction in infection risk. So moving on to the barriers then, we starting again with the patients, we actually commissioned Health Watch, and we've got Kerry with us later today to talk to us about some of the things that they heard from within the conversations they had with around 50 people that had undergone a remote consultation recently. And what we were hearing from that group of people, in addition to all those positive comments we've just talked about, was that there were some barriers around digital poverty and accessibility. Patients were reporting that they perhaps didn't have the technology available to access the appointments. We were hearing from non-English speaking communities that remote consultation was maybe a more difficult way to receive their care. We were hearing from hearing impaired people that the technology was more difficult to have a telephone appointment due to the inability to lip read. So some things there that were around inequity of access for those patients. But moving on to some of the other barriers that we saw. So in terms of the workforce, I mean, the resounding message from the workforce obviously was the huge amount of pressure that the teams were under over the last couple of years, and just the general lack of capacity and headspace to try and embed new ways of working. We're also hearing from the workforce that there was some provision of training, but perhaps not quite enough in terms of how they were to go about delivering this new model of care. From a clinical point of view, we actually heard a little bit around an increase in diagnostic interventions, and that's due to the fact that the kind of threshold for referral was a little bit lower, as clinicians were saying they were less confident when they didn't have the patient in the room with them, and this similarly obviously was creating a kind of reduction in discharges as well. From an operational point of view, I think just the general message that this is a huge operational challenge, and the scale of it should not be underestimated. The implementation of this involves many new processes, redesigning clinic templates, redesigning the booking processes. All of that redesign in the background is massive, and has in some cases been underestimated. Barriers in terms of leadership and culture. We were hearing from some people that there was no strategic rollout plan at an executive level, or perhaps there'd not been an approach to address the cultural and behavioural and mindset changes that really go along with this kind of large scale change and are essential to gaining clinical buy-in. And then finally, on a digital front, we did hear reports of insufficient hardware, clinicians having to share equipment or equipment being fairly low spec, and quite poor interoperability between the multiple systems that people were using. But moving on to some of the more positive things, so we did actually hear lots of great stuff in the system around people working really well with remote consultations, lots of enablers for spread. Starting off operationally, we heard around teams that had mapped the entire pathway to make sure that they set up a really effective service, teams that were profiling their patients for the kind of best appointment method for each patient, and allocating them appropriately, teams that really invested in development time with administration colleagues, just generally quite positive things to ensure the operations ran really smoothly behind the setup of the remote consultation. From a leadership point of view, it was the teams that had taken a really collaborative approach to kind of establish a core leadership team for the adoption of remote consultation, and that team was multi-professional, so including operational managers, clinicians, people from finance, IT, administration teams, to all work together to ensure the smooth rollout across the trust. And in those cases, quite specifically having dashboards that had really specialty specific targets associated with them. So really recognizing that each team was individual and was going to approach this in quite a different way. And then finally, on a digital front, those teams that were working well were reporting that they'd seen quite a big investment in the hardware, that they had dedicated IT support, that there was really good remote access available for staff to work from multiple locations. So again, loads of enablers for the adoption of remote consultation coming through. And that brings us really to the kind of closing remarks of our presentation. It's just highlighting some of the recommendations for next steps before I introduce our panel members to help us continue this conversation further. And so what the report kind of recommends here is that we encourage trusts to take a look at this and try and develop implementation plans off the back of some of the barriers that we've heard around from colleagues in the system, that there is an opportunity to be innovative here and to do things differently, especially in terms of digitizing workflows. That if we want a full digitized patient journey, that we need to really look at the full pathway end to end, of which remote consultation is only one element of that, and perhaps considering a larger scale change program across the region would be a way to go about that. And you can see many more recommendations there on that slide, but as I'm sure you could probably gather, we could talk forever on the content of this report, but it is in the chat, so I'll ask you to have a little look at it if you haven't had chance. And in the meantime, what I'd like to do is introduce some colleagues that we've worked with across this process, and really get into some of the key points that we want to discuss today and get into some rich conversation. So on that note, I'm gonna invite Peter Jenkinson back. We've met Peter once already today. He's the Chief of Digital Operations for NHS England Improvement Northwest. Hiya, Peter. Morning. And then we've got Sharon Livesey with us as well today. So Sharon's the Outpatient Transformation Programme Digital Manager for NHS England and Improvement Northwest.
Good morning, everyone.
Hi, Sharon. We have Laura Atherton. So Laura's a consultant physio and the service lead for therapy outpatients for Southport and Orms Kirk Hospitals.
Morning, everybody.
We have Dr. Andrew Hill, who's the consultant stroke physician at St Helens and Knowsley teaching.
Good morning.
We've got Pete Bonnick with us, who's service manager for specialist perinatal mental health services in Lancs and South Cumbria.
Morning.
And finally, last but not least, we have Kerry, who is the director of Healthwatch Lancashire.
Hey, everyone.
Great, and I think we should have everybody on camera now. Andrew, I'm not sure you're on camera there. Are you okay? Yeah, yep. Brilliant, fab. So in that case, if we can just kind of get cracking with a bit of a conversation off the back of the report. And so if I could just kind of ask you really what you feel are the most pertinent aspects regarding the adoption of remote consultations.
Well, I think that through the work that we did at Healthwatch, the public did come up with some great recommendations, particularly around how we make sure that patients and people have a voice in all of this and have a choice about these things. So, people spoke to us a lot about having the option of having a telephone or a video consultation, or, in certain cases, how they actually wanted it to be face-to-face, because it may be meeting a new consultant, for example. So yeah, it was, we just kind of heard that, patient choice was particularly important for people.
I do think we need to raise awareness that remote consultations is even an option. I do think in certain areas, I think certainly with some of the sort of the feedback that we've had in general practice, that video or remote consultations is seen negatively, when actually there is, as we've seen from the report, there is some huge benefits, particularly around sort of, from patient benefits. So I do think sort of being able to raise the awareness that that is an option at the right time for the right people, that will be helpful.
I think that's going to be quite challenging for secondary care in particular, when we're trying to actually describe, because it's a very patchwork set of services. So patients are accessing those services sometimes relatively infrequently, and different services look differently and have different configurations. And so there's a real challenge, I think, for describing to the patients what options are available to them in each of those services, and making it feel consistent in a way across a whole patch.
And that co-design for patients is imperative, isn't it? And as we've kind of talked about, that it isn't about one size fits all, and it's about having those conversations. And I think some of those co-produced conversations with people with true lived experience are the ones that really give us that real insight into what some people are thinking. So for example, when we initially went forward with our virtual, and when I'm speaking about virtual, I'm very much talking about video consultation, that very quickly afterwards we did some focus groups with patients and having those conversations, because if you like, the kind of the feeling that wasn't necessarily true was that those patients who are a little bit kind of more elderly may struggle with virtual consultation. But in actual fact, what we found was those patients that were maybe a little bit more elderly were very keen to try it and wanted the support in trying to do it. They either did it already through kind of church community groups, or they'd already been contacting their son in Canada for many years via Zoom, and this wasn't a new concept for them. In actual fact, it was those much younger patients who didn't necessarily want to see themselves on screen, like you can see me. I know kind of currently I can't see you, but that kind of interaction they didn't want. And so there are an awful lot of things that we can do on the system to facilitate that and enable that for certain groups of people.
I agree with that feedback, Laura. And we spoke to people that had visual impairments, learning disabilities, and those two groups particularly said that communication was could be challenging for them on a call. They spoke a lot about just struggling with hearing and understanding what the health professionals were saying online as opposed to in person. And I think a lot said about how they just felt rushed, so they didn't have time to collect the thoughts and then ask the questions they might have done in a face-to-face setting. So yeah.
I think the configuration of it, the ease of use, the ease of login, and the setup of that by the service is so important in getting that experience right, isn't it? So it's very interesting. A lot of my patients, so they will have language problems as a result of their stroke. We've also had some patients who've required an interpreter, and it's very easy for virtual consultations to be done badly in that sense, particularly if you're using telephone and rather video consultations. But at the same time, you can also do things exceptionally well if you deliver that. So, it's much easier, for example, for us to put translator services on if you've got video that supports multiple people, because it's actually easier to coordinate a virtual consultation. And when you deal with some of the patients we've had with dysphasia and cognitive problems, what you learn from their home environment and the way they're able to interact with you from home gives you a much greater and richer picture for them, because they're often more relaxed than it would be taking them very much out of their environment and into the clinic setting. So yeah.
I think some of those points, Andrew, are really important, aren't they? And are also really valuable to know that kind of the first contact with a lot of our services and booking of that appointment is with our admin staff, isn't it? Yeah. And so for those patients to be given that reassurance, so something that we invested heavily in was getting our admin staff kind of into the consultation so that they kind of firsthand, again, had that real lived experience of this is what the consultation will include. And equally using those admin staff really valuable feedback that they were getting when they were getting constant telephone calls to say kind of it's 7 clicks before I can get into this appointment, like Andrew was saying, making sure that it is really, really accessible. And so then going back and looking, right, well, how can we change those hyperlinks so that they're arriving in an email? How can we do those test sessions with them? And again, it was about working together as the whole team. That isn't necessarily a skill that, or even an interaction that needs to be given to the clinical team, but by us all sitting down together and having that conversation, when that person rings up who actually would quite like to try video consultation, would like to try virtual, but you know what, is a little bit apprehensive and is a bit nervous and doesn't really know what it is. Where if you've got somebody on the other end of the phone who's very clear about what is going to happen and how that may happen and how they can support you, and also signpost you to, we also need to make a lot better use, don't we, of our kind of community and voluntary communities and sectors to facilitate us in this way. So for example, age concern, I know that there are numerous others kind of going out and doing that buddy type service, because as Andrew was saying, some patients have a much better consultation in an environment which is familiar to them and puts them at ease, so that then they're able to do that. So if we can facilitate them then digitally by enabling them, either if it's with kind of a device that they
I think we might have just lost Laura there for a second.
Need to use or how to turn it on. They don't know which press. This is all to add together as the whole about how we can do. Sorry, my connection is poor. Is it gone?
No, I think you're back now, Laura. We did catch most of that. No, that was a really interesting point that you were making there. But let's maybe stick with the theme of digital exclusion and I think, Pete, in advance of in our chat today, you were telling me a little bit about some of the kind of hubs that were developed in your area. Do you want to maybe pick up on that?
Yeah, we were looking at, when we first started launching online consultation, whether to aid that inclusion in difficult to get to areas such as South Cumbria, looking at hubs in local GP practice. Obviously, the pandemic has caused issue with being able to get rooms, things like that, but it's certainly something we want to consider so that our patients can travel to those closer areas and not travelling quite a number of miles to see us and still be able to join in online consultations with us. So that's something that is certainly what we want to work towards and what we've been considering ever since we started with the online consultations.
Yeah, brilliant. And maybe like flipping this point around a little bit as well. I mean, obviously digital exclusion is a huge challenge, and it's something that we should address. But I think, Sharon, you had some points to make around the kind of converse of this in actually some cases being more inclusive.
Yeah, I'm going to say certainly at the outset of the pandemic, when we're getting lots of sort of initial feedback around sort of the reaction to video, because you know, it was something that only a few areas in the Northwest had trialled before COVID hit. And then suddenly we were providing that sort of digital capability across the region. And it was nice to hear stories of sort of, you know, parents who had appointments to take the children into hospital. And typically only one parent could take time off work to then, you know, do the travel and actually attend the appointment. And we heard, you know, where both parents were able to dial in. And again, we got lots of really good feedback, certainly around sort of paediatrics, where the child actually being in their home environment was a lot more natural and more willing to sort of interact with the clinician during the consultation. And we also had the feedback around, you know, different family members being able to join into a consultation, because again, typically it was, you know, patients typically only take maybe one person with them along to an appointment, whereas, you know, the ability to do it, so certainly with video, you know, multiple members of the family could have that sort of URL link to dial in, and you could then have that sort of joint conversation. So again, taking it the flip side, it wasn't digitally excluding, it was more digitally inclusive. So again, it's balancing out the fact that, you know, again, for the right people, there are options.
And just to add to that, in perinatal, we found it really helpful for the fact that co-parents are able to join. If they were working or something like that, they wouldn't have been able to join an appointment, but we found that they could pop outside and log on to online consultation on the phone. So it was really inclusive as well for those that couldn't join an appointment.
I think that's where operationalizing the delivery of these appointments gets really important, doesn't it? It's very interesting that you know, many patients aren't able to drive themselves to an appointment, but at the same time, if those same patients that don't drive themselves to an appointment aren't able to access a telehealth appointment, you know, we don't necessarily problem solve our way around that and ask families to support as much or those sorts of things. And that's something we've got to get right. So if we get the operational elements of delivering these remote consultations right, that should probably help uptake quite a lot, really.
The feedback that Healthwatch heard would definitely support all of those things. You know, people told us as well about, well, we've already mentioned sort of saving time and it being more convenient. They did say that it's nice that relatives and friends could join the conversations too, but they also said things like they found it easier to access, it saved them money because they weren't traveling and things, and that they actually did find it was more suitable for some of their conditions to do it over the phone as opposed to in person. So yeah.
Yeah, and I think maybe, you know, some of those operational challenges that we're alluding to there, maybe we could start to discuss some of those and how they might be impacting the services and how maybe we could start to address them. I don't know if anyone has any thoughts on that.
I will just talk about we developed a, as you were saying before, about profiling service users, patients into groups, looking at RAG ratings to aid our clinicians, along with a pathway that would give them another tool to look at, making that decision about whether a person should be offered the online consultation or a face-to-face visit, or even a telephone call. So we felt it was important to be able to give our clinicians those different tools, so they sure they can use patient choice, as you were saying, alongside those tools, and finally their ultimate decision on the risks and everything else involved with that, to ensure that we're doing that whichever appointment safely.
And maybe, Peter, that's where the things come in that Laura was describing earlier around, because it's certainly what we heard too, in terms of people saying, we'd be more than happy to have a video consultation, but I just need somebody to show me how it works, just need a bit of training, or I just want a bit of a trial run in logging in, so that I don't have that pressure at the time. So I kind of think during that process, feeding in that sort of patient voice and helping them to kind of co-design some of them initial building blocks, I think would be really useful too.
Yeah, absolutely. And we had lived experience people on our projects when we were starting to build it, and that was very helpful, getting that feedback right from the start about how they felt about the different software platforms and how they felt about those face-to-face. And we found actually the same, that we struggled with those initial assessments being on online consultation, for exactly what you've just mentioned about not really knowing how to use the platform and not knowing the person previously. So we have found that the follow-ups are much better attended.
I think it is
I would certainly agree with the follow-ups. Sorry, I mean, when the national targets were first given to us at the start of the pandemic, it was very split the targets between sort of 25% of all sort of outpatient appointments should be done virtually. But then they were targeting 6% of follow-ups, and then this financial year, the follow-up target disappeared, and we ended up with this sort of arbitrary 25% across the bowl. I do think targets, sort of arbitrary targets, are unhelpful. I do think they are helpful because if you're targeted, or there's a particular focus on something, that's more likely to change behaviours. I think we need to just be mindful of, like I said, talking again and getting feedback from clinicians, they often felt that having had a diagnosis made with the patient and that rapport built with the patient between the patient and the clinician helped with the follow-ups. And I do think that said, certainly at the start of the pandemic, we were trying to target all appointments because, again, with the situation that there was no alternative, we couldn't do the face-to-face. But I do think now, as we're sort of coming out of the pandemic and we're looking at the lessons that we've learned and looking to build this as business as usual going forward as another tool in the toolkit, I do think there is that bit around, clinicians do still need to see patients face to face. They'd still need to get their hands on the patients, and it's this bit around perhaps the follow-ups where you've built that can then be utilised as where you would give the option on remote more than perhaps a face to face.
Yeah, I think it certainly makes outpatient planning much more challenging. I think because as clinicians, you do need to understand which patients really aren't appropriate for you to deliver a face-to-face appointment for because of the clinical challenges, alongside at the same time trying to balance which patients would prefer to access a face-to-face appointment, and getting that balance right and being able to do that in a certainly in terms of patient booking and planning clinics in such a way that you might have a mix of different clinic modalities within the single clinic is really difficult to get right, and something that we have to do with clinicians that are confident in understanding the differences in their patient cohorts. And I suspect that will mean that there will continue to be some variation for some time. And as you say, unfortunately, the difficulty if you try and just go with a blanket target on that is it doesn't allow us to control that nuance. But at the same time, you need drivers for clinicians to take up and deliver new technologies, such as virtual consultations where it's appropriate.
And that is a significant challenge, Andrew, isn't it, in terms of kind of that different mode of delivery of clinics, because as much as we want to offer patient choice and equal kind of making sure that the consultation is the best for that patient, we are also kind of stuck within rigid template kind of lists, which are also kind of hindered even more in terms of space and all of those kind of things, that it's not just purely driven by the booking of that appointment, that those slots do have to kind of be predetermined. Something else that we found really kind of useful is that when we do a consultation, or when you're trained into doing a consultation as a clinician, you're very much kind of watched and assessed from day one in how you deliver a consultation. And kind of 17, 18 years ago, when I kind of first did my initial training and have carried on doing the training, it's always been about face-to-face consultations. There's never been any kind of training and competency delivered on virtual consultation. It was one of the first things that we did, that we delivered some training to our staff, and then assess kind of in terms of their competency and ability kind of moving forward. So that not only means that the patient is getting a really good consultation, but that the clinicians, it's a very different way of treating for them. And as much as we talk about kind of equity of access and kind of facilitating our patients in how to use these technologies, in actual fact, we have a workforce that also needs to be upskilled and facilitated in using these technologies. And we have to appreciate that the workforce kind of has been absolutely kind of battered and bruised in every single way, and then we're asking them to do something new and something different, and we need to support them in the right way so that they can deliver their possible best, which then means that obviously that consultation is going to be the absolute best for that patient too.
Yeah, it's an excellent point, that, Laura. I mean, that came out, really, really strongly in the report. The people that we were speaking to definitely heard around, provision of training in the technology, but not necessarily, like you say, in the kind of mode of delivery of care. But I think, Sharon, you had something to add there as well, didn't you?
Yeah, I was just about to say that, I mean, we flagged this with the sort of the national team that during the start of the pandemic, there was training around, like I say, utilising the actual software itself, rather than sort of, clinicians come out of training with that sort of hands-on experience and not the digital side. So we became aware of the Midlands region. They're actually, they'd already started to look at doing some sort of clinician education training around digital. And the national team are looking, I think the actual clinicians are going through the training during February and March of this year. There'll be an evaluation period. And I think the hope for that is to learn the lessons around whether that particular type of training is beneficial, whether there are outcomes, does it need tweaking, but actually, could we then scale that up nationally? Because I think there's been recognition that, like I said, that clinical training element is missing and is something that does need to be addressed. So I'm just keeping my fingers crossed, like I said, that we get, from the evaluation of that pilot, that we get some sort of good results and we can then take that forward.
Yeah, and I think what we've heard throughout our conversation here is we've heard quite a lot here around some of the operational challenges and the training challenges and the exclusion challenges, but probably what we haven't talked so much about yet is some of the leadership and cultural themes that underpin some of these issues. So I wonder if anyone wants to come in on that. Oh, I can see you trying to speak there, Peter, but we're struggling through sound.
Can you hear me now?
Yes.
Right, I'll start that one off then. Apologies for that. I think getting the culture right and the leadership right is really important. So Laura covered some really important points there around trying to make sure that you build this into your ongoing training as part of it as a clinical professional. And and some of the other conversations earlier around how you then start to pull that in. Well, that means a real commitment from trust leadership and regional leadership and national leadership as to this is definitely something we need to be doing, and then start to build some of those resources around it. We put in, as with a number of things from a digital perspective, we put in a lot of tech to do stuff. People have grabbed it and run with it because we've had to do it. And it's then trying to build on that and build on it sustainably. So we make sure that it's we're doing the right thing and we're doing it for the right reasons and we're going to get the best results out of it. So if you start to look at some of the pathways that are coming out, I think around some of the MSK pathways and some of the cardiology pathways that have come out, there's a very clear, here's something you can do digitally to enable that pathway. Here's a particular toolkit you can use that you can support it with, whether it's a piece of remote kit you can use, whether it's video consultation, remote consultation, whether it's patient initiated follow-up. And we're starting to get those pathways now where you've got a far better idea of where you can sensibly plug digital into that clinical pathway and that patient pathway where it makes sense, and work that through with the clinicians. And those have been worked through with the clinical community, so they're well worked through, but we are still at the beginning of this journey, so there's a long way to go, and that cultural and that leadership ownership needs to be there to take us on that longer term journey to get us where we need to in redesigning services. Thanks.
And Sharon,
I agree with that, Peter. Go on, Sharon, sorry.
No, go, Laura, go.
Okay, so I was just going to say that kind of I agree with that, Peter. And as a kind of a clinician that has a number of different hats, kind of working across Cheshire and Mersey as well as within kind of the organisation as my substantive post, what would be your kind of top suggestions for someone like me who has a very successful kind of virtual service that has done and values the importance of co-production as a golden thread that goes throughout it, not just a one-off, but actually is using this co-production and lived experience throughout it, has kind of looked at that clinician kind of upskilling, if you like, as well as increasing of confidence. What would be your top tips for someone like me?
I think, you're doing a great job doing it. So I think that the key thing from my perspective is how do we then share that learning across? How do we make sure that the work that you've put into it is then made available nationally, so you can start to work with the national teams to be able to look at those pathways to say, well, how can we build it? Are there other things we can be taking advantage of? Are there things that we can work through with Health Education England to work through how do we get some of that into training, clinician training at an earlier stage? There's a lot of learning that's come out of the Northwest. And although we're going through how can we make it sustainable, I think one of the key things is in the Northwest, when we introduced video consultation, we were one of the highest users from a regional perspective across the country. So we really went for it and really used it, and we've got some key lessons we can learn. And I think it's sharing that and making sure we've got a forum where we can share that from a clinician and an operational perspective, and share that across, not just within Southport and Ormskirk, but across that broader community, that integrated community, and also share that then across into the other. And so picking up on the work in Lancashire, South Cumbria, where they're looking at the hubs, how's that going to work? How could that be adapted to work in Cheshire and Mersey? Is that a model that could be used? But it's doing it in a way that's in a learning environment and a sharing environment, rather than from a personal perspective. I think you're going to get a far better buy-in from people if it's done as that a learning and appreciative learning perspective, rather than a hard target than saying that everybody's got to have a surgical hub which does this. We will get national targets which tell us effectively we've got to be doing things along these lines. But if we get that culture which says, well, there's a good piece of learning from the work that's been in Southport and Ormskirk, how can we apply that to Stockport, or how can we apply that to East Lancs?
Yeah, and that rings really true with what we were hearing from many people. I'm sure you were about to say the same, Kerry, is that, that what we were hearing from clinicians was a huge desire to learn from each other and to understand what was working well in other locations. And I think that's probably one of the most resoundingly positive things that came from the inquiry, is that we didn't speak to a single person that didn't think remote consultation had a place somewhere, and that didn't think it was a really positive move. I'm not saying everybody thought it was great for everything, and in some services that was perhaps only a small place, but everybody thought it did have a place, and was really positive and enthusiastic about it. And I think if that means that there is the will, doesn't there, in the system to, if some of these operational or challenges that we've discussed today can be addressed, then that's a really positive way forward. So perhaps I'll invite you, Sharon, to kind of close this discussion out with maybe your thoughts on what the next steps for the region will be.
Thanks, Charlotte. I mean, the report, like I said, gave us such rich insight that, like I said, from a regional perspective, we were really looking for. Now we've got it, and there's just such a wealth of information in there. We obviously want to work with systems and trust. We want to support you, and what we've sort of said is, we've got a remote consultation working group that's just been set up. We set it up just before Christmas. The ambition there is to to be able to highlight, like I said, the areas of best practice, to perhaps where there are challenges and barriers, to be able to provide that sort of critical friends. We can bring the thoughts, bring the ideas, bring the issues, and through the sort of the regional and our links with the national team, attempt to try and put that support in place. Like I said, we're very much from a sort of a regional perspective, with areas of that extra pair of hands to help. So if there are things, like you said, that we can share with others, things that have worked really, really well, do bring it to the team. More than welcome to like I said, work with you. And like I said, the report was fabulous. So thanks, guys, for doing that on our behalf. It's very, very, very helpful.
Well, thank you, and I think we'll probably bring it to an end there on that really positive note, a challenge for the future and a way forward. So thanks so much for all of our speakers today and your contributions to the discussion. Thank you similarly to everybody out there that took part in the inquiry itself. We know how busy everybody is in the system, and giving up your valuable time to contribute to that is greatly appreciated. And as you can see, we are going to do something with that and take that forward. So that's brilliant. And then just finally, thank you to everybody online listening today for coming along and joining in this event. So have a great rest of day, everybody.